Right, good afternoon, everybody. Welcome to the first webinar in our 2026 webinar series for hepatology and transplant. This is Avash Kalra. I'm one of the transplant hepatologists here at the University of Colorado, and I'm the course director for the webinar series. I think we have a really great lineup and really appreciate your time. For those of you who are watching this live today, it's a busy time of year, obviously, after a holiday weekend and heading into summer, but I think this is going to be a really great talk. I do want to just mention a couple of things before we get started. Lindsay Carter is going to put in the chat information about CME and claiming CME for this, so look out for that. Please ask questions during and after the talk. You can actually enter those during the chat, so you don't have to wait until the end, and Dr. Wieland will address those after her talk. The other thing I want to point out is that on the webinar website that you used to register for this, the full schedule for this year's webinar series is on there. So in July, we will have a talk on Wilson's disease. In September, there's a talk on alcohol-associated liver disease. And in November, a talk by one of our transplant surgeons on updates in living donor liver transplantation. But for now, let's get to the main event for today. Dr. Amanda Wieland, a colleague of mine, an associate professor of medicine here at the University of Colorado, is going to give a talk on MASLD. She's also, in addition to a clinical transplant hepatologist, she is also a co-director for our dual at-risk MASLD clinic here at the University of Colorado, which I'm sure she will touch on. Dr. Wieland, thanks for giving today's talk, and take it away.
Thank you so much, Dr. Calder. I really appreciate you coordinating this and inviting me to talk today on something I get excited about, which is updates on MASLD. So we'll dive right in. I forgot to put in my no disclosure slide, but I still have no disclosures relevant to this talk. Diving right into our educational goals for the day. So we'll talk a little bit about the background on steatotic liver disease in general and kind of go through the algorithm of how we define MASLD and MASH. And then we're going to focus on the importance of at-risk fibrotic MASH. And then we'll learn about those current tools in diagnosis and also tools in management. So you guys are probably all aware that there was new nomenclature that came out back in 2023. We used to have what we called fatty liver disease, and then it was either alcohol or non-alcohol, which there's a lot of problems in that inherently. So we refocused and they changed the name of fatty liver to steatotic liver disease. So that's there at the top. And then coming down, the first question that comes up. So when you see steatosis or fat in the liver on imaging or on a biopsy, however that might be found, that's the first finding to kind of decide that there's an issue going on. Then the next thing you're going to ask yourself is whether or not there's any of these signs of metabolic syndrome or these cardiometabolic criteria. Now, what are those? So the main criteria that are highlighted for MASLD are going to be these 5 characteristics that are part of metabolic syndrome again. One of the prime factors is the overweight or obesity, which it is important to note that is that central obesity. And so weight circumference is utilized, and there's different cutoffs for different ethnicities in different parts of the world. So elevated BMI, then we're going to be looking at type 2 diabetes. Insulin resistance is really core to this. Then cholesterol, triglycerides, low HDL, and blood pressure. So those are all characteristics that are going to be enriched in the MASLD population. So once you've determined that, you're going to get a better sense of what's going on. Then you need to get a good alcohol history. So obviously teasing out the role of alcohol is very important for lots of reasons. So to really be pure MASLs, you want to have pretty minimal alcohol intake. So different for women and men. And you can see there, I'm not good at the math. So the 20 grams is about less than 2 drinks per day for women. And then 30 grams for men is going to be 2 to 3 drinks per day. So less than that, you'll be able to feel pretty confident this is mainly driven by the metabolic issues. Higher amounts of alcohol, then you're going to be going down these other pathways. If you have neither of those, you can see you can go over into this kind of other causes of steatosis, which can be medications, other rare genetic causes, some miscellaneous things like thyroid disease, Wilson's disease, which we'll get a whole talk on that. And then, of course, cryptogenic is something to think of as well. So again, overall, we're going to be really highlighting today MASLD, where you're going to have the fat in the liver and these metabolic risk factors. Noting that the drop down there, MASH, technically MASH is going to be a biopsy diagnosis, although we can suspect it without a biopsy. So we're not always biopsying these patients to prove that, but MASH, as we'll go through, is defined by the histologic criteria. So why are MASLD and MASH important? I mean, you guys know this. You're showing up to hear about it, so that shows me you're motivated to learn about it, and you've probably all seen it. Up to a third of our population, if not more, has metabolic liver disease. Then up to 1 in 5 of those with MASLD will actually have MASH, the more concerning form that we'll go through. And up to 1 in 25 can progress to advanced liver disease, cirrhosis, and it's becoming the leading indication for liver transplant is actually metabolic liver disease at this point. It really is MASH that's associated with more increase in risk, although any steatosis is going to have some health consequences, of course, but it's really MASH with inflammation and damage happening that's really got the increased mortality. So who develops MASLD? As I already mentioned, it's really enriched in these metabolic things. So two of the key things are going to be the obesity and the diabetes. And if you look in morbidly obese individuals, up to 90% are going to have signs of fat being stored in the liver. So it's really part of that issue, especially when diabetes is involved. Now, the spectrum of MASLD, there's a little normal happy liver there, all nice and pink. You can see there, once the fat accumulates in the liver, they're going to get these big globs. And once that fat that's being stored there starts causing inflammation and damage, that's what we're going to call MASH. And that's what can lead to cirrhosis. So yeah, I might show you more liver biopsies than you want today, but I think they're pretty and important. So the MASLD activity score, also known as the NAFLD activity score. So this is what the pathologists are going to use to communicate if somebody actually has MASH. So there's three findings on the biopsy that are going to define MASH for you. One is obviously steatosis. So you need to have steatosis or signs of fat being stored in the liver, and they'll grade that based on the severity. And they kind of do this eyeball where they look, is it over 5%? Is it 5 to 30%, 30% or greater, up to 60. So I've seen some that have like 80% steatosis. So there can be a pretty impressive amount of steatosis. Next characteristic we're going to be looking at is ballooning. And ballooning is that's that big, unhappy, swollen hepatocyte right in the middle of the slide there. And that's that sign of apoptosis or cell death. So that's showing that the fat is actually causing enough damage to lead to cell death. And then, of course, the amount of inflammation is important. So it's this usually lobular-based type inflammation that we see in MASLD, and it's kind of a mix of all kinds of different cells. If you have enough points to have 5 or greater, that is felt to be consistent with definite MASH. The 3 to 4 is more borderline, and less than 2 is really not meeting criteria to be called true MASH. Some pathologists will say that you need to have 1 in each category, but there's some variance out there. But in general, that score is what's used to define whether or not they truly have MASH. One of the important things that this is used for, these scores, is actually for clinical trials. So clinical trials, had to have a way to really know that they were treating the right thing. And so early clinical trials that we'll go through were always biopsy-proven MASH, and having a score of at least 4 or greater was one of the defining characteristics of being a part of those trials. Now, fibrosis. So fibrosis is obviously the main thing that links with poor outcomes. So from a liver standpoint, once you start getting fibrosis progressing in the liver, that's what really worries us as hepatologists. So the fibrosis defined histologically for MASH is obviously if there's no fibrosis, that happy liver I showed you, there will be none of the blue. This is a trichrome stain. So it's the kind of stain that highlights the fibrosis. The blue is the fibrotic part. So the first 2 boxes there, the perisinusoidal and then periportal, are 2 different patterns of fibrosis that we see. The perisinusoidal is those little blue things outlining the cells. We'll call it chicken wire, or we see that. And that's a very classic form of fibrosis that we see in MASLD. The periportal is also seen as well. And actually having both of those is what gets you to a stage 2. So if you have one or the other, that's going to be stage 1. Stage 2 is where you have both of those types of fibrosis. Stage 3 is where you're actually forming those little bridges or bands within the liver. So those little bands of scar tissue will get you to a 3. And then 4 is where you're going to have those well-formed nodules for the fibrosis. And again, the bland steatosis very rarely will progress to NASH with cirrhosis. It's really MASH with fibrosis that has that risk. And when you look at that, this is looking at MASH with fibrosis and kind of the associations with either all-cause mortality or liver-related mortality. And then looking there, you see that fibrosis stage from 0 to 4 that we just went over. And it's really this inflection point at 2 where you start seeing an increase in all-cause mortality in individuals with MASH. And then from a liver perspective, also there's this inflection point at a stage 2. And then obviously goes up much higher once you have stage 3 to 4 as well. So it's really the stage 2 fibrosis that we talk about and have been looking for because this is the clinically significant fibrosis. 0 to 1, even though they, have metabolic concerns and that is an issue for their health, from a liver perspective and overall, it's a lower risk group. So it's really these people that are developing at least stage 2 fibrosis that we start to worry about. So how do we find these high risk individuals with MASH with fibrosis? They're out there. There's millions of people out there, but it's, we can't go biopsying every single person. So we have to have a thoughtful approach. So I still like this algorithm, and this is what most of the societies have a variant on this where, and this was put out by the AGA and a nice clinical screening pathway that they came out with in 2021. And if you go to the top of this, this is really geared towards, the front line of, healthcare in our on our patients. It's going to be the primary care, endocrine, gastroenterologist, individuals that are seeing these providers that are seeing these individuals with multiple metabolic risk factors. So this is a tool to look at identify at-risk group and acknowledging there are limitations to this and it'll probably evolve over time the best way, but this is a big start to start thinking about this and being thoughtful about finding these at-risk patients. So diving in, this is up to that top part. So first you want to identify at-risk patients. So in general, if somebody has 2 or more metabolic risk factors, you want to start thinking about this. Type 2 diabetes on its own is really a major risk factor for having concerning MASH. And so that highlights this. And a lot of the diabetes societies are really pushing thinking about this in their patients that they're monitoring. And then, of course, if somebody has steatosis on imaging or elevated liver tests, we want to think about MASLD as well. You get a good history, and then if you do the alcohol history, look for other causes of liver disease from the blood tests, and then you're going to think about the role for your non-invasive tests. So these initial tools. So the main one out there is going to be the FIB4. So FIB4, I like how it's named after how many values it has, and it has 4 values. So it's the AST, ALT, age, and platelets. And so you might all be realizing that those are all pretty easy, cheap values to get. Those are something that all these patients should all have pretty easy to review. So it's a quick and easy test. And our Epic, they actually have a little dot phrase. It'll just calculate it for you and put it in there. So it makes it very nice and easy. And then once you have that FIB4, because you're not going to do this hand calculation at all. So if you want to get something that'll calculate this for you, I personally can't do anything that advanced. Once you have them in these different buckets, you can see that it's based on this low, intermediate, and high risk groups. So the low risk group, you can be pretty confident that it has a pretty good sensitivity, and you should really feel confident that they don't have significant fibrosis at that time. The intermediate group is very much a gray zone. It's unclear, hard to say, and so you want to dive a little deeper in that group. And then there's the ones that have quite a high FIB4, and it's appropriate to think about just sending them to a hepatologist. Obviously, looking at other reasons why their FIB4 might be high, but this is kind of the general buckets people are going to fall into. Now, I did want to do some caveats on the FIB4 test. It is the most widely established non-patented blood-based tool, so it's out there, it's easy to use. It does have the limitations. I already mentioned this gray zone range of the 1.3 to 2.67 has the kind of lowest accuracy. It's pretty low sensitivity and specificity. So the test is good on the extremes of the spectrum. A really low score or really high score, you can be more confident, but there's a lot of gray zone. A lot of people fall into this gray zone. Also, once patients are older, age is in there, but once patients are older, over 65, it really should shift to less than 2 being the low risk group, because this is kind of overemphasizing age as the risk factor. And then it also performs poorly for those less than 35. So if you're looking at something where you're going to make an intervention, you're worried about long-term outcomes, missing things in a young group is very problematic for sure. So there's a lot of work ongoing to find a better measure with improved accuracy while maintaining cost effectiveness and kind of keeping it simple. But for now, this is actually a pretty nice way to start things. Now, I wanted to highlight another tool that is gaining some traction, the fibrotic NASH index. And who knows which of these other blood-based tools is going to come out. But this is another one just because it's nice. It has just AST, hemoglobin A1C, and HDL. And this is taking into account that, one of the biggest risk factors is the degree of metabolic disease. So the hemoglobin A1C and HDL populate in there. And this, they looked at the fibrotic NASH index compared in 244 biopsy-proven MASLD. And you can see I highlighted the FIB4 versus the FNI. You can see the sensitivity in this particular group for the FIB4 was pretty terrible, 32%. That is not a good sensitivity for this test, where the FNI actually had a pretty good sensitivity with those cutoffs you can see there. And in general, high sensitivity is going to let you rule out severe fibrosis. So you're going to want this kind of a test to have a good test characteristics. And obviously these are all based on the pool and the group that you're looking at, but it is an issue that's come out that FIB4 is not perfect, but it is something. But as we get better tests and better ways to do this, hopefully we'll kind of continue to update our algorithms. So going back to our algorithm here, so now we've got our FIB4, and then the next step is going to be looking at the liver stiffness measurement. And I'm pretty sure all of you guys have heard of a FibroScan at this point. That is one of the more common liver stiffness measurement tools out there. Transient elastography is going to be the main name there. You can see a few different machines there. And so this is a nice way to try to tease out that big bucket of gray zone. And so these liver stiffness measurement tools, the main one out there again is FibroScan. There are other ultrasound elastographies. FibroScan is the most validated and most common system available. I personally find it the easiest to interpret because you can actually get the waves, and it's usually within a GI clinic or an endocrine clinic or a primary care clinic, where it's a kind of point of care that you can do, and you just have a little more control over the quality. And so it's overall my preferred, but ultrasound elastography is another option. And again, that low score of less than 8 is the general range that we're looking at to have a 93% sensitivity to exclude advanced fibrosis. The other liver stiffness measurement tool is the MR elastography, and it is a nice tool if you have it available. Both of these are reliable or less reliable when there's inflammation. So if your liver tests are above 100, you might start to get nervous. You're going to get, it might elevate the score. Also with hepatic congestion, heart failure, that can make the score, the liver seem stiffer, and also with infiltrative diseases. And just real briefly, you can see there the elastography, and when the operator just puts it between the ribs, they push a button and it thumps several times, and it's generating the shear wave that moves through the liver. The speed of that wave through the liver tissue is going to correlate with density, and you get these little shear waves, and basically the slope of those lines. That slow one is going to be a nice soft liver, and if it's fast and really steep, that's going to be hard and stiff. Now, MR elastography is a nice tool if you have it. It has different ranges, and you can see there's these different stages that correlate, and they can be anywhere from normal and then increasing fibrosis, and you can see cirrhosis is in the 4 to 5 range. And it is a nice tool. It is supposedly the most accurate it is the most accurate non-invasive method for staging liver fibrosis by the literature. However, it's really only marginally better than the other non-invasive tests, especially for stage 3 to 4. So it's really not recommended as first line. But I found it to be a nice tool as I'm following at-risk patients, because we get a little more consistent results. It's also more accurate in those with obesity or ascites. It is more costly and not widely available. And again, while it's more accurate, I've found in real world using it, there's also challenges where if you're having them done outside, kind of the quality metrics and knowing if you got a good scan or if there was technical issues, the operator has to circle an area of interest. So the radiologist will kind of find one of those areas and circle that area and then average out that density. And so knowing if that was done correctly, I've just, in the real world had some challenges. So everything out in the real world has challenges, as we all know. So there are other blood-based tools out there that are kind of more accurate, more expensive. So the ELF test, though, is the one you'll see out there. And these are blood-based proprietary tests that use these different biomarkers that often fall into the family of these different collagen proteins. And so that's how they're trying to look more at this question of fibrosis. So the ELF test also has these different cutoffs that you can get to kind of rule out different degrees of fibrosis. And It is something that you can utilize if you don't have a liver stiffness measurement tool. It is used in clinical trials to help with screening. So it is a pretty good test. I will say I haven't personally sent it because we have pretty good access to the liver stiffness measurement tools, and that's in general recommended before the ELF test. Cost is also a question. I haven't personally sent it, so I don't know how well it's covered or what the cost would be for it. So, but it is a send out test that you can send it off, but I haven't personally done that. So. Now, role for liver biopsy. Should we still be biopsying people, or can we just use all these fancy tools I just told you about? In general, there is still a role for biopsy. It would be my take home. It's important in confirming the diagnosis. If the serologic workup or there's clinical suspicion for some other cause, it is important part. Certain things like autoimmune hepatitis, if you've got positive markers or a family history, or there's something in your clinical suspicion, it is very appropriate to proceed with a biopsy to confirm. The other reason to do a biopsy is if you're getting conflicting non-invasive testing. And I will say the more you do these and follow these, the more conflicting results you get. So at some point, I found that, as I follow people with at-risk MASH and looking for response, every few years thinking about a biopsy is not unreasonable. So it's something that I think still definitely has a role. And if it's important in making a final decision on treatment or a medication decision, I'll kind of have that shared decision with the patient about proceeding with the biopsy if we need it to kind of make a final decision. Whether or not you need it to actually start pharmacotherapy that we're going to go over, the short answer is no. The guidelines from the societies in general say you don't have to have a biopsy to initiate treatment. That being said, might you do that to kind of finalize if it's the right thing? Yes. So it's going to be, again, a very individualized for the patient decision, but you don't necessarily have to do it. So getting into the management, the primary management for metabolic liver disease is still meaningful lifestyle changes. And we never want to forget about this. Our new meds and all this is very exciting, but it really is important to emphasize and really work with patients to help in these meaningful lifestyle changes. Sustained weight loss. We know that 5 to 10%, we see very meaningful improvements in histology if people can get there. In general, counseling them on the general dietary things, limiting portion sizes, really trying to work with somebody on long-term healthy habits. These are, lifestyle changes, not like going on a diet. And exercise is, of course, important, even if they're not losing weight. And so I always like to emphasize that really treating the whole patient with MASLD is really this multi-tiered, multiple provider approach. It really takes a whole team with the patient at the center. I had a different talk I gave and asked AI about what the components of care in MASLD were, and they did put hepatology up top. But then you can see endocrine, cardiology, nutrition, PT, OT, primary care is very important, obviously, pharmacy, their mental health, and then, these other optional groups to tie in to really meet these goals of dealing with the underlying metabolic syndrome. Primary care being number 6 to me was always not the right approach. In general, the primary care is really the champion that is finding these at-risk patients and getting them to the right individuals. We really count on our primary care team within our system. They do a great job we have different resources, these built-in algorithms to, point them down the path of who to consider doing a FibroScan and then who to send to us so that we can talk about pharmacotherapy. All right, so and that kind of leads me up to what are the medical treatment options, medications for at-risk MASH. So looking back, this has been a long road. MASH was proposed back in the 1980s. And then over the years, all kinds of things have been tried and failed. There really wasn't much that stuck as far as really meeting the main endpoints. And there were 2 big endpoints for the clinical trials that the FDA mandated to really say that something was going to be able to be approved for treating MASH. One of them was the MASH resolution without worsening fibrosis. So those histologic characteristics that we talked about, that NAFLD activity score, getting that score from 4 and above down to 3 or less, that was one of the big things. So stopping the inflammation, stopping the damage. So you had to see that as a significant change. The second endpoint was improvement in fibrosis by at least 1 degree without worsening the MASH. And so that was really an important thing as well. So those were the 2 things that the FDA laid out as this is what these studies need to be powered to find if this can be done. Now, there's been a lot of work. It's an understatement to say this is a multi-billion-dollar industry that's been looking across the spectrum of all the different causes. And this is meant to be a busy slide because it's been, every different mechanism out there has been looked at. And then it was the fall of 2023 when the Maestro trial came out. So Maestro NASH, I'm assuming my audience has probably heard of resmetirom. So resmetirom, it's a pill. It is a medication that, of all those many pathways I just showed you, it works by binding to the thyroid receptor that's specific to the liver. So my dumbed down way of thinking of it is that the liver is relatively hypothyroid or low thyroid activity in metabolic liver disease. And but when you rev up those thyroid receptors, it helps clear out the fat and decrease the inflammation. So this pill, it was utilized in this phase 3 trial, Maestro NASH, a year-long trial with almost 1,000 participants. These are all biopsy proven with a NAFLD activity score of 4 or greater, so pretty clear MASH. And they had at least F1. Most of them were 2 to 3 fibrosis, so pretty significant at-risk fibrosis. And they had the placebo versus the different dosing arms. And the primary endpoints were what I just went over with you, resolving MASH, or improving fibrosis. And then, of course, they looked at the safety. You can see here they met their primary endpoints. There was the placebo there was only about 10%. And then in the MASH resolution, you had up to 30% resolving the inflammation, and then up to about 25% had the fibrosis improve. So not a major change, but in general, with a year of treatment, seeing that improve was a big win. And then in general, if you look at this, this is just highlighting that kind of general shift. So there's the placebo versus the different dosing of resmetirom, and you can see that red is the improvement. So only 15% on placebo improved. You can see the whole thing shifted. I mean, not getting worse is huge too. So only 18% got worse as opposed to 34% in placebo. And then the NAFLD activity components you can see there. Again, those different bars are reflecting that the improvement in the NAFLD activity score was much greater on the treatment doses. So we were seeing a real effect of resmetirom. And overall, it was very safe. I will say, in having used this medicine for a while now, it's overall very well tolerated, no major adverse events. There are these GI issues that come up, diarrhea, nausea, a fair amount of time that will improve if they stay on the treatment. It kind of abates over a few weeks. So you tell them to kind of see how they do. Most of them feel better. I had one patient who started it and said it was the golden pill that took away all of her ails. So that was a very strong placebo effect, I think. But in general, people seem to tolerate it well. So with all this data, resmetirom Rezdiffra became the first FDA-approved therapy for at-risk MASH in the spring of 2024. So we've had this now for a couple years, and we've been treating patients with it. Now, how do we decide to use resmetirom? So when this first came out, the ASLD put out some very nice guidance for these new medications. And so you can see that middle column there in the green is ones that if you have a patient with metabolic liver disease, MASLD, and on your non-invasive test, you can see that top one there, the VCTE, so that's your transient elastography. If their stiffness measurement was between 8 and 15, that's in the sweet spot, that's a good candidate. Or an MRE of the 3.1 to 4.4, that's also right in that sweet spot. Or if you have a liver biopsy in that F2 to 3. And so that's a key group to offer this medication. The top bar is really focusing on the fact that this is not approved for cirrhosis, and especially those cutoffs in there are really looking at individuals that have true cirrhosis with kind of the early portal hypertension. A FibroScan score of greater than 20 really does suggest they probably are bordering on nearing cirrhosis, or they are cirrhotic with portal hypertension, and an MRE of 5 is solidly in the cirrhotic range. So some of you might do a lot of these FibroScans and see the numbers and realize, and there also is a gap there between 15 and 20. Like, what are you supposed to do? And that's what that bottom bar is about. It's like you can consider individualized decisions on using this if people fall out of these ranges. It's just highlighting that this really was not studied yet in true cirrhotic. And so this is focusing on those that were proven in the study to have benefit. The studies are ongoing right now on resmetirom in the cirrhotic group, and things are looking promising, but we're still waiting to hear the results on that, if it has a benefit in cirrhosis or not. And you can see in the fine print there, again, a liver biopsy is not routinely recommended for staging of MASH. So it is not routine. It may be appropriate in an individual, but it is not necessarily needed before you make a decision on treatment. Now, once you start treatment, what do you do? What's the plan? Is this something somebody's on forever? Like, how do you assess? So this is also as part of those ASLD guidelines. It's nicely outlined there that once you start treatment, if you go down, you're going to be, whenever I start treatment with resmetirom, I'm always in my mind thinking, okay, what am I going to know to know if this is working? Whether it be elevated liver tests, or am I going to watch their FibroScan, or is it their MRI? So having a nice baseline and feel like you really know where they are is really important when you're starting a medication. In general, this medicine's about $4,000 a month, I think. So, while it's safe and potentially effective, you want to be thoughtful about, what we're using for our healthcare costs. And of course, we don't want to use it if it's not helping the patient. So those different boxes there, that first top box is really if they are having no signs of improvement. So at the 12 months, which is based on what the study was, if they have worsening of their non-invasive testing, or if they have an increase in their liver test, that it's really not helping, you would stop. The green is go for if you show improvement, and they define improvement that's significant by the stiffness measurement change of greater than 25% improvement, or an MRE of greater than 20% from the baseline, and then also normalization of their ALT is also a thing you could watch, and so you'd want to continue going. And then that gray zone, the yellow, is kind of if things are stagnant or only a little bit better, do you want to continue? One of the things that, does suggest that the resmetirom really is working is improvement in steatosis. We do tend to see the steatosis improve more quickly. So looking at the MRIs that give you a nice measure of that. So lots of different tools to decide, but that's the general algorithm. This doesn't really fully common this idea of, is this forever? Like, if they go down to a stage 0 to 1, do you stop? No one really knows. It's something where you can try stopping, knowing that you would potentially need to restart if things get worse again. And those are all things that, again, are going to evolve over the years as people are on these meds and we see how they work in the real world. We'll get better guidance on that. All right, and then comes the spring of 2025. So about a year ago, the Essence trial came out. So the Essence trial was looking at semaglutide. And so semaglutide, I'm sure you guys have all heard of semaglutide as one of the GLP-1 family. So this was utilized, and it's the formulation was Wegovy, which is the weight loss version of semaglutide, and it was the sub-Q injectable weekly formulation. And so this was a 72-week trial. So that's one thing to highlight. This is actually over a year that they treated patients, like a year plus. And 800 participants. Again, this was biopsy-proven MASH. They had a NAFLD activity score of 4 or greater to really feel confident they had active MASH. And then they had F2 to 3 fibrosis. And they were on placebo versus the standard dosing of the semaglutide with the standard escalation. And the outcome was, again, resolving MASH or improving fibrosis. And you can see there, very impressive. So the placebo response, interestingly, the placebo response, it was more like 10% in resmetirom, but just saying semaglutide near people, apparently they had a 34% response. But then you can see the amount of resolution of MASH, so the inflammation resolving, was up to 62%, so very impressive. And then you can see fibrosis at a year plus was up to 30, almost 40% there if you're really round up. So impressive response. So more potent than Resdifra. And so this became the second FDA-approved therapy for at-risk MASH in August of 2025. So that officially became available for that indication. I didn't put it in here, but the side effects are more with the GLP-1s. There's definitely more GI, and actually staying on GLP-1s for various reasons, cost, efficacy, is challenging for patients. So there's other challenges there, but if they have access to it and can be on it, it is a very good option to highlight. Now, just delving in a little bit or diving in a little bit into the GLP-1s in general, you guys are probably familiar with a lot of these names. The GLP-1s were the first ones that came out back in 2005, and there have been different formulations through the years. You can see it was in 2017 that we first got Ozempic, the diabetes version of semaglutide, and then it's just been off to the races with all these different formulations, and we are going to be getting some triples and all different kinds of things that'll be coming out. So even more pertinent in this class. The main ones in the GLP-1 family right now to highlight are going to be, so with semaglutide, you guys are probably aware. So again, the Ozempic is for the diabetes. Rybelsus is the oral version for diabetes. Wegovy injectable was for weight management and now also has the FDA approved indication for MASH. After that, we actually now also have oral Wegovy. So hasn't been directly studied, but again, we would think it should be very effective. And then tirzepatide. You guys are have probably heard of that as well with Mounjaro and Zepbound. I will say while Wegovy is the one that is FDA approved for MASH, there really is a lot of data to suggest there is a pretty good class effect for these, that they all have benefit. I don't anticipate that these specifically are going to have any direct FDA indication. But if you jump all the way back to the initial diagnosis of metabolic syndrome and diabetes management and weight management, no matter where someone is on the spectrum being important, utilizing these medications early in the treatment of MASLD is very important. So that's getting back to having a primary care know that if they have access to these through whatever way they can get them for a patient, they're a very good option because we know that they have a lot of efficacy. Now, the medical decision making for using semaglutide in MASH. So again, the ASLD did a very nice job of coming out with some good guidance for us. So in Hepatology in 2025, they have this nice algorithm. You can see it kind of mirrors, or they flip the boxes around just to confuse me. But the top box is now the reasons to add it in. So again, it's basically the same criteria. You've got your liver stiffness measurement by transient elastography or MRE. You've got your blood-based, they included ELF in this one as well as another tool to use. And then, of course, histology. Then you've got the gray zone area where you can consider it in carefully selected individuals, and then places that it's really not recommended. I think the biggest group is going to be cirrhosis. So those with cirrhosis using this, especially with portal hypertension, it is not FDA approved for that. And again, it's a very similar algorithm. You decide, you start, and then you monitor safety, and then you're going to assess response. Notice this response assessment's at 72 weeks, mirroring the clinical trial. So they actually are suggesting keeping them on a little longer to kind of give more time to see that effect. And if you have those improvements that they have outlined there, continue it. Not quite there, you might reevaluate. If they're getting worse, you might stop. Now, this is all assuming you're only using it to treat the MASLD, because these meds are also treating, the number one cause of morbidity and mortality in our MASLD patients is actually cardiovascular disease and issues with the diabetes. So whether these meds are being used and titrated for that, you may continue them in that situation. So that's another important thing. But if you're just looking kind of with the narrow view of is it helping the MASLD, and honestly, some of this is, can you keep getting it covered by insurance? Or these are the criteria they're going to use to keep authorizing it. And that's something that gets complicated and muddled very, very quickly in the real world, as a lot of you probably know. So my little summary here. So pharmacotherapy for at-risk MASH, while it's, exponentiated in the last couple of years, it's still only 2 that are officially approved for stage 2 to 3. And so going to be Rezdiffra and then semaglutide. And then one thing to know is we really don't have the data yet to know about the combination, kind of when to start which one. We definitely had patients that we started on resmetirom, and then semaglutide came out. It's like, well, do we add it in? And so, it's individualized decision making. Whether or not we want to throw the kitchen sink at somebody and just use every mechanism you have to reverse them and peel away. That exactly what is going to be the guidance is still evolving. So it's not been studied. There are clinical trials and studies going on that looked at combo therapy where there's actually like 2 things at once to see Because if you're looking at the whole spectrum of MASLDs, you've got the inflammation, you've got the fibrosis. So certain things target the inflammatory pathways and some try to reverse fibrosis. So you can imagine, depending on where someone is on the spectrum with their liver, that might help inform which therapies you're going to be using. But we're just excited to have anything that has effect. So really, again, a patient-centered decision on which one to start. A lot of our patients will already be on a GLP-1. And so we meet them and they're really, switching to a different GLP-1 or switching to Wegovy may not make any sense. So if they've been maxed out on GLP-1 therapy, then adding in Resdifra would make a lot of sense. Another group, lean MASLD. So if somebody really doesn't have diabetes that needs helping managed or doesn't have these other metabolic things going on, maybe Resdifra makes sense in that patient as well. The benefit of it being an oral pill versus the injectable, although we now have oral Wegovy. So it's nice to have tools, but it has added some complexity in the decision making of which one. Now, what are the options for cirrhosis, stage 4? So if somebody's officially a stage 4, what can we do? The studies are ongoing, but there's currently no approved therapies. You can consider the GLP-1s to help with their weight management, but you have to be cautious with GLP-1 therapy and cirrhotics. In general, one of the things you have to watch for with GLP-1 therapy is when people lose weight, they're going to lose muscle and the fat. And the ratio of how much muscle they lose is going to be more in people with underlying chronic liver disease and more advanced liver disease. So we always have to watch for sarcopenia. So you may not have a great window for that. So once somebody has portal hypertension with decompensations, thinking about actually liver transplant and just resetting things. And then you get to treat the recurrent MASH after transplant. So that's another role that we have in the liver world. So again, the clinical trials are ongoing. What trials we have here at the university, we're always looking to have options available for patients that aren't responding to our standard treatment. One of the big groups is these cirrhotic patients. So in general, a cirrhotic MASH patient is one that we currently have one clinical trial going on, and we're always looking for more because that's a very underserved group right now, trying to have those individuals and kind of get them pulled back from the brink. And that leads into a quick case presentation I wanted to talk about for you guys. Kind of a bit of a story of success, I like to think. So back in 2022, this 58-year-old female was referred initially to the UCL endocrinology department for her diabetes management. And she had very difficult to control diabetes, was on a very complex regimen. And looking back, her endocrinologist recognized that she had a biopsy that had been done back in 2013 that actually showed she had F3 fibrosis. So in her workup and testing, she got a repeat biopsy here at UC Health that confirmed she had active MASH and she had progressed to cirrhosis. She was F4 fibrosis on her biopsy at that time. And then she was referred, and I got to meet her through, as Dr. Kalra mentioned, we are set up to try to kind of have a multidisciplinary approach to these at-risk patients. Our clinic is set up where we have a hepatologist and an endocrinologist, myself and Dr. Jensen, and we see patients that have been found to have kind of more complicated metabolic liver disease, MASLD, with at-risk fibrosis, sometimes compensated cirrhotics, post-liver transplant. So we see kind of these more complex patients. And then between the two of us, we make decisions on getting them on treatments, optimizing their diabetes. That's Dr. Jensen more than me. You don't want me managing your diabetes. We follow them and have been adding in these medicines. And so we met this patient and we're following her through the years, and through aggressive lifestyle modification and optimizing her on GLP-1 therapy. She actually, by 2026, had lost significant weight. She went from 200 pounds down to 134 pounds. Now, her imaging was still saying she had cirrhosis, and we were following her with non-invasive testing that was giving us kind of mixed results. And we were trying to tell whether or not she had developed portal hypertension. And ultimately, her liver test had normalized. And for various reasons, we decided to get a repeat biopsy to help guide therapy. I think one of the big decisions we were trying to make was some of her testing suggested that things had improved, and we were trying to decide if she might need resmetirom added in. And so we did her biopsy. So you can see here back in 2022, all that white there is the steatosis. And that zoom in there is active MASH with inflammation, and that's a sad little ballooned hepatocytes. So active MASH and inflammation causing damage back in 2022 when we saw her. The 2026 biopsy, you can see like almost no steatosis at this point. So her steatosis is gone, really minimal inflammation, really no active MASH. So her MASH has fully resolved. And then also very impressively looking at her trichrome. So the trichrome again is we're highlighting fibrosis. Back in 2022, very clear thick bands, so nodule formation. So this is, you can see that bottom piece there, pretty clearly stage 4 cirrhosis. 2026, our pathologist called this a 3, but you can see there, like that is a major change from her original biopsy. She's got like a few of these little bands, but really she has reversed her cirrhosis. And I've had a few of the fellows come rotate in our clinic, and we have a lot of patients like this that were advanced fibrosis cirrhosis, and then on their serial testing, things really start to improve. And I mean, I tell my patients all the time, the farther along it is, it's harder to reverse, but given enough time and with all these different tools, you can reverse cirrhosis. So pretty exciting for her. And she's doing well, and we're following her and hoping she'll continue to do well. Because one of the issues is maintaining. Like she's actually had some weight regain, and it's all right in the middle for her, but we're going to try to maintain and see if we can reverse things even further. So a few little take homes, closing thoughts. So kind of again, diagnosing MASLD, it's really all about finding that at-risk MASH. So really finding the fibrosis, finding these at-risk patients that we need to be more aggressive with and very proactive. The FIB4 is still the best thing we have, although I kind of like the FNI, so using all these different tools, and hopefully we get better and better algorithms so the right patients are getting to the right team members. Liver stiffness measurement tools, FibroScan and MRE are both good ones. ELF is also an option that's out there. Less of a role for biopsy, although still it still plays an important role when you're getting conflicted results. Management, never forget about the diet and lifestyle change. Our patient that we reversed, most of it was just through, coordinated care through our multi-D team and getting her on the right meds. We had her on GLP-1s before Wegovy was even approved because there was no reason not to with careful management. And then with the stage 2 to 3, thinking about all these new meds that are coming out, resmetirom, semaglutide. For cirrhosis, we need more. And so there is really still a role for thinking about patients that are kind of in these gaps right now and thinking about having them sent for clinical trials. I think cirrhotics are really a big group, especially the pre-portal hypertensive cirrhotics. That's a group that we really need better therapies for. And that's my end. All right. Thank you guys all for listening and hanging around for my MASLD summary. So yeah, there's a little bit of time if anybody has any specific questions. I don't know if I have to push any buttons. Do I stop sharing? I see a little thing.
Dr. Wieland, thanks for the great talk. It looks like there's 2 questions in the chat. I can read it for you.
I found it.
Okay, great. Go for it then.
Yes, so I found the one that says, could you elaborate on evaluating for thyroid disease when thinking about starting resmetirom? Yes, so in general, the guidance is really just checking their baseline thyroid levels. And I will say they're going back to the original slide, they kind of have it in there. The endocrinologist I work with likes to check some like reverse T4s and all those things. That's not fully needed. It's somewhat of our, a new med that's just approved. We just wanted to kind of see in the real world what was happening. But yeah, it's in the algorithm there to kind of monitor for that. A history of thyroid disease is not a reason you can't have them on resmetirom. It just needs to be well controlled. So. All right. Were there other ones in there? I think that was the main question I saw.
Yeah, there are a few more in the chat.
Oh, okay. That was the question and answer thing. Okay, I don't know where the chat is. How do I find the chat? Oh, I see it now. Okay, I found the chat. All right. Oh, wow, you guys were listening. Okay. All right. Okay, so first one from Dr. Lazada. So in the absence of a liver biopsy, how am I clinically making the diagnosis of at-risk MASH? FDA utilizes terminology, but we're shifting to fewer liver biopsies in the era of VCTE, and elevated AST and surrogate for steatotype. So one thing to know is that actually finding MASH, none of these tools are good for MASH. We need something better for MASH. We're good at the fibrosis. So the surrogate that the ASLD and all these cutoffs are more for fibrosis. So whether or not they have active MASH and would actually fit into what the trials were really still requires a biopsy. We don't have great tools to find MASH. So yeah, I guess the clarification from kind of how I presented it was that when we're using our VCTE and these, it's really more looking at fibrosis. So in using the ASLD guidelines, we're probably offering treatment to people that don't have active MASH. But it's the best we have because some people with normal liver tests have active MASH, and biopsying everyone for that isn't necessarily the right thing in every case. Is it still a reasonable thing to do when you're trying to make a final decision? Yes, if that makes sense. So yeah, it really is using those cutoffs that were from MRI, VCTE, and the ELF, acknowledging that that doesn't necessarily mean they have true active MASH as was on a biopsy. All right, then going to Lauren. Do I have challenges with insurance coverage? Yes. There's a lot of challenges with the medications, and it's almost that the different insurance companies seem to find new ways to confuse me. Because as we've highlighted, you don't need a biopsy to start the medicines. You know, they're on it for a year. You're reassessing efficacy. Some of the insurance companies have then wanted us to give their NAFLD activity score when they're asking if they'll recertify it, which makes no sense because even if you rebiopsy them at that point, that's not the initial one. So sometimes it's just pure insanity what they're asking for. So it has been very challenging. The again, there's almost so many just like anecdotal examples. It's hard to make any broad statements other than you just kind of make your best clinical decision and then do what you can from the insurance side. A fair number of our patients, also have issues with copays. The gov might be covered, but it still might be too costly with copays. We have a pretty amazing pharmacy assistance team that works on getting certain grants to help with that. So there's all these different permutations of all the different challenges for weird things that happen with the insurance companies. I've had it where initially they could pay for something and then all of a sudden their copay went up to $200 a month. So, and it's something where, yes, these medicines help, but if someone's trying to decide about rent or this medication, I'm like, you should pay your rent. So that's a major challenge with our healthcare system for sure. And then how much testing blood work is best to be done prior to clinic visits? In general, for when somebody's coming to our at-risk MASH clinic, we in general, we don't do direct referrals there. It's all kind of internal. So most of the patients are coming for kind of the standard MASH. As Lauren's aware, we see a lot of our post-transplant that are developing signs of hepatic steatosis. In general, we like a FibroScan or a biopsy because the post-transplant will have had a biopsy showing MASH when we're trying to evaluate for rejection or other things when their liver tests are elevated. But it's nice to have a FibroScan as kind of a baseline before they see us in the MASH clinic. But in general, we're kind of, do a deep dive and figure out, we're always finding more things to test as well. And then looking from Jenny Way, at what point would you consider starting carvedilol for varices prophylaxis, especially keeping in mind we do not have excess EGDs in rural New Mexico? Yeah, the question on varices prophylaxis, yes, the liver stiffness measurement tools are a nice guideline for that. In general, if somebody starts to have signs of clinically significant portal hypertension, that's where we start to think they might benefit from carvedilol, the non-selective beta blockers. And there's emerging data that if somebody is going from the very compensated cirrhotic to that early portal hypertension, starting a non-selective beta blocker has benefits beyond preventing varices formation. So from varices bleeding, it can actually prevent them, and there's benefits. So if you have if the platelets are less than 150, that's kind of a general cutoff, or if you have splenomegaly on imaging, kind of any of those early signs, you can use that. And then, especially if they have other reasons to need to be on something that would help with their blood pressure, it's a great medicine to consider. So yeah, I think that's a great option when you have minimal access to actually do a screening endoscopy. If you have access to FibroScan, if the VCTE, if the KPA on a FibroScan is above 20, that's another sign of clinically significant portal hypertension. So there's some nice ASLD guidelines that kind of give some algorithms and boxes for that too. So, all right. All right, and then Avash is asking things. All right, Dr. Kalra. Is my decision for using resmetirom any different if you feel a patient has met ALD instead of purely MASH? Good question. Yes. I I'm hesitant to use resmetirom if somebody's still drinking excess alcohol, I guess is the short answer. Met ALD, defined initially by those general alcohol intake. A history of significant alcohol that possibly contribute if they've stopped, and if I still see active inflammation and steatosis, I'm gonna do that. If somebody's still actively drinking heavy amounts of alcohol, I don't think there's any proven role to use resmetirom. Is probably just not the appropriate medicine in that situation. Some prior alcohol that contributed, but they've really minimized it at this point. I would consider it. So, whereas the GLP-1s are something where if somebody's still drinking alcohol, the GLP-1 family, there's data where it can help with alcohol cravings and decrease their alcohol intake. So actually, in that population, if you can get access to it, I'd favor using a GLP-1 therapy over resmetirom if I was making that decision on what's best for their liver, because resmetirom's not going to address that alcohol use disorder where the GLP-1s might. All right, I think I found all the chat questions. I'm proud of myself. I'm slowly getting better at these webinars. Any other
Well,
questions or?
Dr. Wieland, that was great. Oh, it looks like there is actually one more question rolling in. What is the
What is the
dosing of
dosing of
Wegovy?
Wegovy? Interestingly, I don't really know. So, because I will say, whether or not the standard dosing is the same. Start at the 2.4, you titrate up. I don't actually prescribe it because I am lucky enough to be partnered with an endocrinologist who's prescribed it for years. And so our path in our transplant hepatology clinic has been when we have the at-risk patients that might benefit from these complex decisions on these weight management, diabetes management, that we pull them into our clinic. So, whether or not gastrologist, hepatologists would start to directly prescribe them is up to that provider, but they would have to be able to answer that question of dosing the Wegovy, how to titrate it, have pharmacy support. So that's going to be very individualized to your practice pattern. I do think that GI doctors, hepatologists definitely can if they feel comfortable and they've got the right support around them. What's a little challenging is, again, these patients, so many of them have diabetes. So if they're on other diabetes medicines, like, our team was like, there's just not that many of these that you have to think about, adjusting those meds and all those things. So we really thought it was best to partner with groups that had more experience with the GLP-1s and focus on that than prescribe them directly ourselves. So I don't actually know the dosing of Wegovy off the top of my head. I apologize. Good question, though. All right. All right,
Well,
Avash.
Dr. Wieland, that was fantastic. I think that was very practical. And I certainly, thanks for answering my question also. Much appreciated. Thanks to everybody for joining today. Please claim your CME credit. The information's on the website. It was included in the chat earlier.
Thank you, everybody. I appreciate your caring about metabolic dysfunction associated steatotic liver disease.
Great. Thank you again, Dr. Wieland.
Thank you, Lindsay. All right, so I just head on out.
Yes, you can go ahead and log off. Thank
All right.
you.
Thank you. Appreciate y'all. Yeah.